Given the high rates of Aboriginal and Torres Strait Islander pregnant women smoking still, given the burden of disease and other generations that are implicated, I'm just wondering if we can look forward to oral and nicotine replacement therapy being on the PBS, and how do we go about that? What do we do? It's kind of a no-brainer.
I'm sure there's a complexity of issues underpinning that, and I know that it's been called for, and it continues to be in the mix of funding choices and policy priorities. But take it on that that's still out there, and no doubt in our minds that it is. But we just need to continue to look at that amongst all the other conflicting priorities.
This question is for Professor Hoek. My name is Ada. I'm from WHO and the Suva office in Fiji. And in the Pacific, one of the issues that we've had is that some of the smokers choose the package that they smoke based on the actual graphic health warning. So they think that cancer is a long-term disease, so they'll choose that. They choose the pregnant woman because they think it's like lighter. So I just wondered in your focus groups if you've ever found that similar situation, or if the POS ban has helped eliminate that issue.
Thank you. We certainly find a lot of evidence of smokers who say that they go into stores and select a particular warning label that they feel, for whatever reason, is going to be less relevant to them. And when we talk with retailers as well, they will also report having had those requests from smokers. I think one way around that is perhaps to test our warnings more widely with different smoker groups so that it becomes more difficult for people to evade warnings. Certainly I think retailers find it a little bit annoying to get those requests, so if we can get them on side and just saying, you get the pack you're given, if that's what you want, then that's what you get, then I think there's a lot that we can do to build alliances with retailers in all sorts of different ways that might help us to get them to implement our policies for us.
My name is Alam. I'm a general practitioner from rural New South Wales. My question is for Billie. Thank you very much for that presentation that made me startled about data on people who I every day see. And it is very pathetic to see people in my practice every day with mental health illnesses and issues with mental health, having to go through that situation. My direct question is that in your study group, did you find a gradient of socio-economical differences among the mental health ill people that you studied? And because I was a strong believer, you hit hard the community as hard as you possible, and then that will affect the mental health, that will affect mentally ill patients, that will affect the lower socioeconomic group, where whenever there's time you get a snapshot of a community, you get the total community prevalence will be a lot lower than what the mental health group would have. So that was I was strongly believing, but it has been challenged. Now, back to my question, did you see any difference among that group, that if the patients were much more financially better off, they were much more receptive for the messages, or not?
So firstly, I'm really glad that my data challenged your thinking. That's terrific. And in answer to your question, our sample was drawn from clients receiving emergency relief assistance from community social service sector. They were all highly disadvantaged, so we didn't have a gradient of socioeconomic status as such. But the national data that exists suggests that people who are, say, for example, in lower socioeconomic areas, so they may not have a mental illness, they may be just lower income, Smoking rates, although higher than in more advantaged areas, smoking rates are lower amongst those lower socioeconomic groups than they are in the very, very disadvantaged groups where you see very high rates of smoking. And one theory is that financial stress in itself makes it very difficult for people to quit. There seems to be a link. We don't know exactly the details of that link, but the higher a person's financial stress, the less likely they are to quit smoking.
Thank you. Back again, aren't we going back to the social determinants of the story that we are dealing with? And I think I'll close it from here, let others.
Yes is my answer to that. Yes, they need improvement in their social conditions. Yeah.
Alexander from Ash, New Zealand. A quick question: what did you, or have you read the research that was done in the UK that looked at plain packaging seemed to benefit tobacco companies in that it levelled the playing field in relation to them being competitive with each other? And so therefore the research seemed to suggest that rather than being competition with each other, they seem to favour plain packaging and were able to then invest that money in advertising towards making cigarettes more addictive.
Well, that's not research that I'm familiar with, and I'd be very interested to know who conducted the research, because I haven't seen that come through in any academic journal. I think tobacco companies issued all sorts of threats about what the effects that plain packaging would have. So they predicted that consumption would increase. They predicted that children would experiment more because it would be like a forbidden fruit for them. I don't think that there's any evidence from Australia that any of these dire predictions have come to fruition. And I'd say it's like, the tobacco industry has predicted that the sky would fall in whatever we do, and I think we just have to learn to treat their claims and claims that may have come from groups that have been commissioned by them with the utmost scepticism.
Janet, this is for you. The green stick was a fascinating idea, but the immediate thing that worried me when I saw it was the greenification. We see a greenification of a variety of products implying some environmental benefit, and I wonder whether you picked any of that kind of effect up in your research.
When we did the qualitative study, we tested different shades of green, and that's certainly something that comes through with a lighter green. But the green that we used, which may not have reproduced particularly well, is quite strongly associated with the murky green that's used on the Australian plain packaging at the moment. And overwhelmingly, the feelings are those of disgust rather than ecological or environmental merit. Yeah.
Just stay away from olive green.
I deliberately do. I mean, I've been through that with Mel. I've learned that.
Andrew Penman, for Janet Hoek. All the things you've experimented with, of course, have been visually driven. Have you tried other senses like smell? There's a prominent tobacco control person in Australia who has a particular fondness for the potential use of cadaverine, for instance, as a smell within cigarettes, which would make them smell like rotting corpses, I understand. But have you explored that at all?
Well, no, but I'm always delighted to go away from conferences with new ideas for research. As you say, we have focused very much on visual changes to the pack design, but there's certainly UK research where I have a colleague over there who designed a pack that when you flipped it open, it played an incredibly irritating jingle that encouraged people to quit. But I think even though people found it immensely annoying, I don't actually think it was particularly effective. And yeah, and that's the only, so it was oral sense that was examined there, but that's all I know of.
I have to say, over the years in the department in Canberra, we've accumulated a lot of samples of tobacco products, and we do have a problem with the smell already in trying to store them in a way that's acceptable to the rest of the workplace, so that adds a new complexity to them.
Hi, I've got another question for you, Janet. It's Prudence from the Smoke Free Coalition. How far along are you in advising our government of these further along steps we can take to the legislation? Does it need a supplementary order paper while the legislation is passing through second and third reading, or are you already advising them on these legislative amendments to the Act?
We always send copies of our research to people policy analysts and people involved in drafting legislation, and they've been very interested in the findings that we've arrived at, but I don't have any information on how they plan to progress that. But I have been away for 6 months, so I haven't had an opportunity to meet with them, but it is one of the things that I would like to follow up when I finally arrive home next week.
My second question is to Dr. Lisa Studdert. Having heard Janet's presentation on plain packs, bearing in mind that you're going through some pretty hefty arbitrations right now, but once you win that, what's the possibility of further amendments to your legislation here based on this intel from Janet today?
Well, firstly, thank you for the optimism. I share that. I think we just have to get through what we're getting through. So, but, I think it's fantastic to know, and I learnt a lot from Janet's presentation, that there's already work being done on 2.0, but at this stage, no immediate plans for amendments.
Hi, I'm just wondering, I may be, not know enough about this to know whether this has happened or not, but has anybody thought of putting on a packet a link we can scan with a mobile phone that takes you directly to smoking cessation advice and so forth? Whichever country you're in, it would go to the appropriate authority and so forth. Has that been thought of or used anywhere?
Yeah, people have thought about doing that, and we contemplated including a QR code on our quitline study. I mean, we didn't, simply because the experimental design was quite complex already, but it's certainly something that I think would merit further investigation. But I don't know of anyone who's actually doing that at the moment.
What's your opinion about financial incentives for disadvantaged, given that financial stress is one of the determinants of, or barriers? What do you think about that, for paying people for, quitting?
We've trialled financial incentives, and there was an amazing lack of interest. So even when we offered cash to join a smoking cessation program, people weren't signing up. So the lack of interest meant that we couldn't trial incentives properly to determine whether they would have an impact on actual cessation. I've been involved in a trial that's led by the guys at NDARC, the National Drug and Alcohol Research Centre in Sydney, on financial counselling for low-income smokers, and the uptake of that counselling was a bit more promising, but again, it hasn't translated to higher cessation rates. So, yeah, it's a good question.
Thanks.
Dr. Studdert, for you, David Lester from the New South Wales Quit Line. What would it take to make the 13 quit number a free call number from, I believe the Lifeline number's free now from any phone?
I'd have to get back to you about that. I'm not sure what the background work that has been done on that is, but it's obviously something worth thinking about, but I'm sure it must have been looked at. I'm going to look at my colleagues and see if anyone wants to. Thank you for raising the question, and I'll take that on notice.
I raised this earlier on the conference, but I think I'll raise it again here. Marianne from Williamson Aboriginal Health Council. Incentives, we know, may not necessarily work for a community, but we know that in the mid-90s, the childhood immunisation coverage in Australia was 54%. As soon as we introduced GP incentives, that within a few years was up to over 90%. What would it take for us to have a separate Medicare item number in Australia for tobacco check that GPs, health workers, RNs alike could pick up and use, because at the moment we have only one question in the Aboriginal Adult Health Check 1715, do you smoke, yes or no? And as on-the-ground tobacco workers, we're not service providers, so what would it take to get an item number up so that professionals, allied health professionals, could use it to discuss tobacco with patients?
Thank you, and I believe you raised that question earlier in the conference. So
for the last 6 years, I've been raising this question.
Well,
since I first got into the program.
I have to say, I think there is. I know that the item 715, and I've got some advice on this, does allow for GPs, and I can see our GP here nodding in agreement to ask that question. But I think there's a general expectation that GPs should be asking this question on a regular basis, regardless of the item number. And so I think it's a broader issue about GP education, about support for GPs to raise that and to carry through a conversation, of which I think there are already resources to do that, and an expectation and support to do that. I don't know if our GP would like to comment, but I really do think that there is a lot of opportunities for GPs to do this, and we have to push on to get that. I don't know if a specific item is going to solve that problem.
I think item number 715 and item number 700 to 705, which is health assessments, include smoking assessment part of it, and most GPs do it. More often than those item numbers, most GPs have to ask whether they smoke or not, regardless whether you are indigenous or non-indigenous, because most of the records are now computerized, and whether you document the state whether you're a smoker or not on the medical director or best practice software is one method of accreditation assessment when you come for every 3 years for accreditation of the practice. So one of the tools they use is how many patients in your record base have been recorded as smoking or non-smoking, whether they have allergies or not, no allergies, whether it is noted or not. That is one of the percentage they use to tally the whole practice. So it's pretty widely used.
I'd just like you to join me in thanking our panellists and speakers.